You get there, the patient doesn't look 25. They look like they have a body of a 12-year-old. The parents are talking to me.
That's going to throw you.
Yeah, big time. The parents are trying to tell me what disease he had, something I never heard of before. I look at the patient. He is that classic ashen gray, barely breathing, hypoxic. I remember first thing I did was feel for a carotid. And I'm like, yeah, there's nothing. And I remember looking at my partner and saying, let's get on the floor, start bagging. We're working a code.
To In Service, the EMS Podcast, where frontline experience meets leadership insight. Hosted by Jason Falvey, a seasoned paramedic and EMS leader with over 30 years in the field. This show brings you conversations with people shaping emergency medical services today. From street-level medics to innovators on the bleeding edge of EMS, we dive into real stories, leadership strategies, and what it takes to build high-performing teams in high-stakes environments. Let's get in service.
We copy you down, Eagle. Tranquility Base here. The Eagle has landed.
Today's guest is a paramedic, a registered nurse, and a firefighter. He serves as a fire cares coordinator. His innovative role blends clinical care with community outreach as part of a mobile integrated healthcare program. He administers wellness checks, provides hospital-to-home support, leads free healthcare clinics, and teaches CPR and Stop the Bleed courses. The aim is to meet patients where they are, keep care accessible, and build healthier neighborhoods. In our conversation, we'll explore his journey into the dual role and how he mobilizes medical, social, and emergency services into a seamless, community-centered model. Welcome, Derek Hofmann. All right, good afternoon. How are you?
Good, Jason. Thanks for having me.
Thanks for coming in. I'm really excited to talk about this mobile integrated healthcare, or MIH, in community paramedicine and what your role is. But before we get into all that, why don't you tell us where you're from, where you grew up?
So I originally grew up in South Florida. Kind of, if anybody knows where Broward County is, that's where I was born and mostly raised. I spent my other part of my life up here in the metro Atlanta area and just kind of never left it.
Great. What inspired you to get into EMS?
So I actually was wanting to be a mechanical engineer at first. Went to school and started the prereqs and found out I wasn't that good at calculus. So kind of thought about what can I do? And at that point, I was not great in high school, so needed to find something to make an actual career out of. And I said, oh, you know what? I want to go be a firefighter. Kind of went down that road, and every firefighter I spoke to was like, well, man, I hope you like medical, because that's exactly what we do nowadays. So they encouraged me to go get my EMT to start off with, to be a more competitive candidate. Back then, getting on the fire service was super competitive, and you had to stand out in some shape or form. Ironically, once got into the fire department, did the whole fire thing. Don't get me wrong, still love doing fire stuff, absolutely, but the EMS really took flight with me because I just enjoyed it. I enjoyed providing patient care, enjoyed doing the different skills, and it was more repetitive for me that we were able to do it all the time. And instead, fires, unfortunately, we don't run much fires in a lot of places. So yeah, I kind of tiered towards the medical and have enjoyed it and don't regret any moment I've, even kind of thought about it per se.
That's awesome. Yeah. Well, listen, before we go too much further, I did bring a gift for you today. It's a box of meat from Waleska Cattle Company.
Well, thank you so much.
That's how
awesome,
we say welcome. Big box of meat, right?
Exactly.
So I'll leave that for you. So any calls in your career, because not only are you a paramedic, but you're also a registered nurse.
Correct.
And any calls for you stand out in your career?
So I could write a whole novel on that one. But yeah, there is one in particular that as a newer medic, I was on on my agency's rescue unit is what they called it. So pretty much it's just a medical unit, an ambulance. We go to a call for a post-seizure is what it came out as. And they also had an engine come in as well, kind of our normal dispatch. And I remember when we were responding, I didn't even talk to my partner about it. I was just like, let's just go get it over there. At the time, I was like 1.5 years as a medic. So baby medics, kind of fresh numbers. Guess I had a little too much confidence going into that one, thinking, you know what, maybe I should just cancel the engine, like before even seeing the patient, right? Yeah, we'll find out. That was probably going to be a big mistake if I did that. But we arrive on scene and bring all your normal stuff that we bring for a seizure. And went inside, parents were talking to us, and the dispatch originally was for like a 25-ish year old. You would adult patient is what you're thinking going into the game. You get there, the patient doesn't look 25. They look like they have a body of a 12-year-old. The parents were talking to me.
That's going to throw you.
Yeah, big time. The parents were trying to tell me what disease he has and stuff like that. Something I never heard of before. It's going in one ear, going out the other. I look at the patient. He is that classic ashen gray, barely breathing, hypoxic. I remember first thing I did was feel for a carotid, and I didn't feel anything. And my brain, for some reason, decided, well, let's go check the other side of the carotid. So did double take, and I'm like, yeah, there's nothing. And I remember looking at my partner and saying, let's get on the floor, start bagging. We're working a code.
And, you're going to a call. It comes in as a seizure. You're running through your algorithm. You're thinking about what you're going to give and do. And then you show up and looks like a 12-year-old.
Yes.
In cardiac arrest.
Yes, exactly. Yeah. And I usually in our agency, we'll go over the radio as, just to notify dispatch, hey, we're working an arrest. My brain was so tunnel visioned with that. And it just didn't let go. And I was, real nervous. Like it was just not very calm and collected. And
everybody in EMS has had one of those calls.
Yeah. The more I hear about it, I'm like, and there were so many lessons I learned about that particular call. Fortunately, unfortunately, we did get ROSC on the patient, but due to his disease, kind of put him into a hospice situation later on. However, just like ever since that day, I'm like, not canceling anybody until I see a patient, until I, actually have an assessment done and decide where we're going. And even looking back at that call too, calm down for a second, listen to the parents, see what they had to say, what they had to tell me about the patient, their medical history, any medications he had, would it probably helped instead of, being so reactive right off the rip. Yeah, it was kind of one of those that as a medic, especially brand new, it was like, oh yeah, they did touch on this in medic school, but yeah, I'm living in real times.
Yeah. That's where the basics come in. Yeah. So let's talk about your current role. You've got kind of a unique role with your agency and in what you're doing because you're a nurse and a paramedic.
Correct. Yeah. So my current role, I guess my job title is community nurse / paramedic. So what is that, right? So essentially we have a mobile integrated health program at my agency, and it's kind of expanded to the scope that we wanted to bring in, that nursing aspect of it, right? And we'll play on the key differences a little bit here, or like why is why don't you just use a CP or a community paramedic, model? And we'll touch on that a little bit. My current role pretty much is I still go to 911 calls, which, still love going to them. Kind of like as a QRV sometimes, if that's what it calls, and I'll cancel the engine or...
And what's the acronym QRV? Quick Response Vehicle?
Yes, correct. Yeah, Quick Response Vehicle. So that one, I still go over 911 calls, and, if I need to cancel an engine, cancel the rescue, just because I can handle it, or, I have a ambulance on the way that's there with me, that's great. Sometimes there's too many chefs in the kitchen, right?
Right.
You kind of need to go more line.
He's in the herd.
Exactly. So that's part of my role on the 911 side. But the other cool thing I can do is I can spend more time with that patient. And I'll have a story for you later about it. But I can spend a lot more time with that patient on 911 call. Sometimes with fire, with engines and the fire side, if they're not transporting, is they want to get back in service as quickly as possible because they do have training, or they might have like a PR event they need to get to. And that does play kind of a role in that. My job is this patient. That's it.
Right.
So on 911, I can definitely stay with them longer and sometimes figure out what they need. Like, do they really want an ambulance transport? Do they want to go to the ED? Or is there something on this 911 scene right now that I can fix for them?
Right.
It's like just an acute thing. And if I'm able to do that and, they don't even need to go to the ER.
Let's talk a little bit about mobile integrated healthcare, or MIH. What exactly is that?
So mobile integrated health is an umbrella term for, it could be quite a bit of things. And I always tell people there's no one piece that fits everything in that term. So essentially what we do is a lot of preventive care. We go out to people's houses, just kind of how you would see on 911 call. We go out there, non-emergency. Usually we don't run lights and sirens to their house to do a, simple thing. But it's more preventative things, and every agency is going to be different. Everyone's going to have their own different way they look at it. It depends what that community needs.
Right. In mobile integrated healthcare, all of this started somewhere in the 90s in one version or another. And the goal ultimately was to reduce unnecessary transports.
Yes.
Because it's utilizing a tremendous amount of resources every time someone calls 911.
Correct.
Also to reduce the patients going into the emergency room who could get care otherwise in a more efficient way, in more cost-effective way. But MIH in 2013, the American College of Emergency Physicians released a white paper, and it basically really expanded what you're doing today in mobile integrated healthcare and how we can explore other avenues to route some of these 911 calls.
Yeah, because the way you got to look at some of these patients is they don't got the education EMS provider does, or somebody that works in emergency services.
Right.
To them, it's an emergency.
And it could be something as simple as their prescription ran out. Correct. They don't know how to handle that. They need that medication, so they call 911, get transported to the ER.
Absolutely. And, with MIH, that's something we can tackle. Like, perhaps in that moment, we can't fix it because it's not in that acute situation. We might not be able to fix it, right? However, going forward after that, by doing prevention with that patient, visiting them, even just calling them, how you doing? Is there anything I can do for you? Anything I can help you with? That will help make that situation not happen again.
You're getting them through the process of getting to a primary care physician or to an urgent care or whatever it might be.
Yeah. I mean, I've had patients that they forget to refill their medication sometimes. So autofill, right? Almost every pharmacy has it now. And they didn't know about it for some reason, but that's an easy fix.
Because that 911 call, you're getting an ambulance, you're getting fire apparatus, you're getting a police officer. That's a massive expenditure.
Absolutely.
And the prescription refill is important, but still, there's got to be a better way to do it.
Yeah, exactly. Exactly. I mean, if you look at, FEMA's fees for having an engine itself, it's like, $192 an hour. And that's just basic, just running the engine.
Right. Yeah. And so community paramedicine, tell us about that. How does that fit within the MIH model?
Like I was kind of saying, the MIH is like more of an umbrella term. So yeah, it's kind of think of an umbrella, and then you got like a little peg there, right? And you have your community paramedics.
Right.
They kind of are part of that peg, but also on the other pegs, you might have a physician, you might have nurses, you might have social workers, one that had counselors there. So it's very kind of like, you kind of hear in the name, integrated health, right?
Right.
So you have different disciplines all working together to accomplish one goal with the patient.
Right. And we're seeing a lot more social workers involved because a good percentage of the calls that come through 911 every day are mental health related calls.
Absolutely. Absolutely. Because, I mean, when we look at what EMS is trained on as far as mental health calls, it's to get to the patient to the hospital, right?
Right.
That's essentially the goal of it. Social workers are more trying to get that patient long term to not have an acute psych episode, and they're trying to make them have a normal life, essentially. If you want to put it in
normalized
terms. Yeah. Yeah. I mean, they're just, unfortunately, they have that issue and it's affecting their life that much. They need somebody who's more on top of it and are maybe perhaps more trained to deal with that.
Right. Our training as paramedics is the acute emergency where a life-saving intervention needs to be made to change things. As a nurse, you got a broader perspective.
Absolutely.
The long-term health and care of the patient.
Yes. Yeah. One word thrown around a lot of nursing school, holistic care.
Yeah, good. How do you deal with a patient that is just distrustful of, this is kind of a unique model, right? It's being used in other parts of the country, but the average person calling 911 is probably not aware that this is even an option. And then you arrive and you're a highly skilled provider. Yeah. How do you explain to them, wait a minute, hold on, we have some other options here?
Yeah. Yeah. So, because like you said, Jason, we run this a lot, and it's right. Like we could put up all the social media, all the podcasts, anything, you can about this subject, but it's not going to hit everybody. And then you get the person that calls. So especially when dealing with a patient that's already kind of about healthcare, like
Distrustful, hesitant. Yeah.
Exactly. Like right. It's usually because the neighbor called, right? And they're worried about them or family member, whatever it is. And we actually kind of dealt with this recently. The biggest thing to do is when you go in there is to meet that person where they're at and kind of like, that they probably need to go to the hospital, right?
Right.
It's, you have your signs, but that person, you need to communicate with them and not make them trust you, because well, if that was that easy, everyone would do it, right?
Right.
But just talk to them in a manner like they're a human being, because that's why they hate healthcare. Maybe they were in the hospital and they got treated like trash. But whatever the nurse that they had was never paid attention to them. Maybe the physician they had was rude to them.
And they're using terms that are maybe they've never heard before or don't understand.
Absolutely, yeah, medical jargon, right? That's one thing that people get upset about, and then they ask for an explanation and they don't get one. Right. So that's a lot of stuff that can cause a patient to be distrustful. The best thing I would say when we go to those things is be honest with them, be truthful, and explain it in a way that they understand it and hopefully gets to them.
What is the typical patient you see on a daily basis?
So a typical patient will vary, honestly.
There's no typical in this business.
Yeah, exactly. It's all dynamic, right? Some days it's something called just a wellness check. And like I said, everybody's different. Every agency's different. But in our agency, we have something called wellness checks. So every quarter we go out to the homes of a set list of patients that originally started as vulnerable patients, but that list kind of grew and grew, and we're not going to say who's vulnerable and who's not. If you want it, the service is there, right? Your taxes pay for it. So we might go one of those wellness checks. So it just depends what they got. Usually it's hypertension, right? They need a blood pressure check. Hey, how's your diet? They got diabetes. How's your blood sugar doing? Is there anything weird about it? Have you gotten weird readings? Are you actually keeping a log of all this stuff?
And so you're trying to detect issues before they become big problem.
Correct. Yes.
And treating them there.
Exactly. Like you have, say you got your hypertension patient as an example, and you're looking at their log and they're supposedly taking their medication, but their BP is running 180 over 100.
Right.
Constantly. Every time they take it, it starts becoming a cause for concern, right? Now you got to start kind of putting your mental cap on and think of, okay, we're getting to that point that is going to turn to a 911 call. We need to hit the brake on that.
Right, because they're at increased risk of a stroke or
heart attack, all sorts of stuff. What they call it the silent killer for a reason, right?
Right. So let's get that under control before it becomes something bigger.
Absolutely. Yeah. And then the other one, kind of what we'll see in MIH is called pretty much people that get discharged from the hospital and require a little more care than just the wellness ones like we were just talking about. We're seeing those patients every week, sometimes twice a week, depending on how severe they are.
So you're trying to prevent, in some patients, readmission to the hospital, and there are typically 4 or 5 key diagnoses that you're looking at with MIH. What are those diagnoses?
Yeah, that's right, Jason. So most of them you'll see are going to be asthma, COPD. You're going to see congestive heart failure a lot on there. You see diabetes. Those are going to be your most common readmitted patients that, unfortunately, go back to the hospital quite a bit. They have to have some sort of comorbidity before they can get on an MIH program. I have to preface that because I've had patients try to get on and I go visit them for the first time and I'll be like, so what kind of history you got or something? They'll be like, oh, no, nothing. No. And it's like crickets.
You got 27 medications on your night.
Yeah, exactly. It's kind of like one of those things that like you try to help break it up and have them understand, which is another part of it. But yeah, sometimes you got to send them back to square one, back to the physician, and be like, you need to talk to them and have them really tell you, and then we'll move on from there.
Right. Can you share a story where community paramedicine under MIH made a difference compared to traditional care?
Yeah, absolutely. So I'll give you actually 2. Both of them will be from 2 different views. So the first one was actually came out as a 911 call came out as a cardiac arrest, actually, now that I think about it. So go there, first one on scene, patient's not in cardiac arrest, check the sugar. Sugar is low. So yeah, that was the thing to fix originally. That was the first thing to fix. We go ahead, give them the dextrose. It was noted on the other side of the arm that there was another IV kind of wrap around that person. So you talk to the patient's family and the brother was saying that, oh yeah, you guys were out here last night for the same thing. Okay. So we're raising a little bit of red flags. Right. What's happening? We're talking, the patient doesn't want to go to the hospital. once she wakes up after, the sugar crash and everything. So it's like, okay, again, what we talked about before, hesitant patients.
You're looking at uncontrolled, right?
Yeah, exactly.
Diabetes,
exactly.
which is very dangerous.
Absolutely. Her pressure wasn't that great either after, a liter of fluid, because it was originally low. With that, I pretty much, in so many words, with that story was the engine couldn't stay there any longer. I mean, it'd been 40 minutes of much going in a circle. Same thing with the ambulance unit. Eventually, they had to go back in service too. However, I could stay there. I could stay there and with the patient and make sure that she was actually kind of got fed, whatever it was at that point. That
in this type of patient, you've given glucose, the blood pressure drops, so you're giving them a liter of fluid. There's a real risk that blood sugar is going to drop again.
Exactly.
Right. Everybody clears up, goes back in service, and now
you're out there again.
They're heading down.
You're in your whole D50 story you got, and that's not good for a patient, right? That thick dextrose, constantly just going through those veins, eventually it's not going to hold. So, back on the story there is I sat with that patient for probably like 3 hours.
Wow.
And I talked to her, like realistically, what is it that you're concerned about the hospital? Why don't you want to go to get this treated? Because this is what I'm looking at. I'm being honest with you. Your sugar's going to crash again. And the patient did have a urinary catheter on her that was full of blood. So more big red signs are coming up, right? Like, warning. This is going to turn to a real cardiac arrest later at some point. And, she explained to me that she had cancer. She had going to doctors left and right. She's sick of seeing doctors. Talking with her and just trying to meet her where she is with that and let her understand, look, this is what I'm seeing. This is the data that's been presented to me. And then, I threw another caveat was the brother I think it was her sister that she really listened to. And the brother told me that, like, she really looks up to her sister, listens to her. I was like, well, let's call her. And, I'll talk to her and talk to the sister. And she's like, yeah, like, I agree with you. I think she needs to go back to the hospital. Something's not right. Something doesn't make sense. And it was like, okay. I told her, I was like, look, I can arrange everything, but whatever we need to do, we'll get another ambulance out here. It's no big deal. But we'll make it happen. I'll pack up your stuff for you, whatever you want. Let's get you to a hospital. Though.
She's a very high risk patient.
Exactly.
Yeah.
Thankfully, she finally agreed, got transported, spent a week in ICU because she was septic.
Wow.
That was one story that, and it was kind of nice because I built a relationship not only with the patient but with the sister as well, and she kept me in the loop the whole time. Every procedure or whatever they did at the hospital, this is where she's at now. And then eventually goes to the point, she's back at home. She's doing great. And we're seeing her oncologist and, things are progressing really well. Stories like that, do make me feel like, oh, wow.
You made a difference.
Did something.
You did make a difference.
And then the other one, this one comes in maybe a little more classical through, a referral that we did. But it was pretty much a patient with new onset of heart failure, home oxygen, 2 liters, kind of the normal thing you would see with a heart failure patient. Greatest little lady that I was dealing with. She was down in the dumps because she had previous history of AFib and she just had open heart surgery not too long ago for a mitral valve replacement. And I have hypertension, I got diabetes, and you can tell that she was feeling down on herself and she felt like she would never come back from it. So after that initial visit, start getting resources together like senior services because she fit the criteria to get her transported. I get her doctor's office, Meals on Wheels, low sodium diets for her. And as we're doing that, I think the second visit, she was not feeling good. Had shortness of breath, gained weight, overnight, about 4 pounds. So obviously we're indicating we're building up fluid already. Get a transport unit out there. Engine doesn't even go, right? Because I don't need an engine come. I already know what I'm looking at, and I have the same formulatory they're gonna have. I got her ready, got her everything. We get her transported. I ride in with that patient. I go with the patient and go with the ambulance crew. I have her all her meds. I have her whole history that I can easily just give.
And that's a big point, right? You call for the ambulance. Now that ambulance crew doesn't have to try and figure out everything you just spent 2 weeks on learning. And where she is in the care continuum, you're able to communicate very quickly what needs to be done, where they need to go, and communicate that to the hospital as well.
Yeah, exactly. I already had 12 lead going. We got the IV. It's make that transition as seamless as possible. So on this patient, she got eventually discharged. They finally got the fluid out. Fortunately, even I think she had a total of 6 thoracentesis performed because she was just constantly building up fluid in her lung. And eventually she got out of the hospital. We kind of started scheduling another visit. And actually, this is kind of where a lot of that coordination comes in, right? So the nurse that was in charge of heart failure called me and was like, I already knew her before, but she's awesome. And she kind of told me, hey, I have one of your patients. I'm, talking with her. I'm giving her education. I'm like, cool. Tell me, what are you teaching her? Can you send me the whole thing? She sent me every single thing that they went over, what diet we should do, everything that I needed. I'll give you an update as we go on. Unfortunately, she got out of the hospital again. We did a visit and same thing. We're building up fluid. I think this time her left lung was just completely diminished. I mean, there was no air movement whatsoever. It was just nothing. So we go back and eventually I talked a lot with that heart failure nurse, and she was going to get transferred over to another hospital down a little more downtown to see kind of more of a specialist to deal with it. And I remember giving her all the information. I gave her everything about her environment, how she lives. This is what she's doing. This is how it's looking. She also has this other thing that I don't know if she told you about. And she was like, no, tell me about it. I'm like, so she told me she has kidney issues. Yeah, we're trying to pump those Lasix through. It might be a cause of concern. That's why it's not working, right? That's why she's retaining fluid. She's like, thank you, noted. We'll put in the chart. So eventually the patient got a surgery. That was actually kind of cool. They pretty much put talcum powder inside the lung to prevent fluid from ever kind of building up into there. So eventually she gets discharged, and I could say to this day, she has no oxygen anymore. She doesn't even need it. And every time I visit, lungs are clear, and she's better spirits. She lost weight. She even forgets that she needs to check her legs to see if they're swollen or not in the mornings.
She's feeling that good.
Exactly. And that's another example. That's one of my patients that.
Now, how often are you seeing her or following up on her?
So for her, she started off for just about 2 days a week because we started seeing those escalations, right? We needed to call transport. We need to get her to the hospital. So she started off at 2 days a week. Now I only see her bi-weekly pretty much. Okay. So once every 2 weeks to reward it. Our kind of goal is with those patients is to, have them have a goal in 90 days to be kind of discharged from our program is the way we write it. But when you're discharged from our program, that's a good thing. You can go on this wellness program we have as well, and we'll still see you. But those 90 days are so detrimental because that's where, as we just saw, readmission happens, right? Kind of go back, and now costing a lot of dollars, a lot of issues are popping up. So those 90 days are so imperative. That's why we see those patients, depending on how severe they are, once, twice a week. Really hone down on that education factor. Obviously, medical is always top notch, or they stable first. And then we start going down the education path with them and talk to them. You talk about their diet, exercise. I mean, you get a lot into that social aspect. Hey, where's your family? Are they nearby? If you needed to have transport to the grocery store, how do you do that? And things like that. Like it really, really hones a person as a whole rather than just looking at them as a diagnosis.
And that's really where your nursing background comes into play.
Absolutely.
Yeah.
Yes.
And that patient you're describing, additionally, you might see them who's not getting the follow-up care. Their condition would get exacerbated. 911 would be called. They'd go to the hospital. They'd spend the time in the hospital. They'd be discharged home. Everything would be fine for a little while, and then
we're right back at it.
You're right back, and it's this revolving door. And so you're really making her quality of life better.
Exactly.
Is really what it is.
When I originally saw her, she said, I have done 5 thoracentesis. I'm like, excuse me? How many? And she said 5. I'm like, well.
Describe what that is.
So essentially what it is they're going in, just make it nice, easy layman terms. They're going with the needle because you got fluid around your lungs and they're draining it. And it's all ultrasound guided. Usually physicians are doing it, and they're just trying to drain that fluid, because what happens is that fluid starts wrapping around your heart, your lungs. It's going to make hemodynamics really hard. So your blood pressure might start collapsing. You might have trouble breathing. So it's those important organs that you really don't want fluid around. The only fluid you want is your heart pumping that blood and moving it in and out, right?
It puts pressure on everything, and it doesn't work as well.
Exactly. Yeah.
What are the biggest challenges you face in MIH, whether it's clinical, logistical, or financial?
So you can kind of hit on all 3 of those factors in MIH right now. It's kind of the concept is now, it's kind of the new kid on the block in this sense. I know, they've been doing it since the 90s. However, it's coming to light now, right? So clinically, your mindset changes in MIH setting because, one, you're like, all right, we gotta stabilize the patient and get them to the hospital, right? No, and at MIH, you are essentially trying to bring the hospital to them. You're trying to figure out how do they not get to the hospital, and some people, it ain't gonna happen, right? They're gonna need a lot more higher level of care. But for the ones that you can, you start thinking, okay, what can I do here right now that might be able to fix this, so that way they don't have to go to the hospital. In this MIH setting, is there something that's going to, clinically, is there something right now that I'm looking at that's about to become a big problem? So that clinical aspect, you really gotta shift your mindset, and it's not so much reactive. It's a little more that mix of preventative stuff. And what can I educate them on? Talk to them and teach them some stuff. Teach them what you know about certain things, like how to, this is the diet you need, a low sodium diet. Okay, well, tell me what does that look like, right? And, even if you don't know, here, I'm going to Google it myself so we both learn and we'll find, solutions to it. So clinically, you're not thinking of, man, I got to treat this set of signs and symptoms. I'm trying to treat a whole person.
Right.
Altogether.
And time isn't necessarily a factor as it would be.
Correct.
In a traditional EMS.
Absolutely, yeah, and that's where the thing lies is you're going to spend a lot of time with these patients. You're going to develop a relationship with them, and sometimes it ends heartbreaking. It doesn't end up the way you wanted, and those patients pass on, and you kind of develop a relationship with them, and you're like, well, it's not just some person I took a 10-minute ride to, to the hospital. This is a person that I've seen for 6 months now and spent maybe 100 hours with them, and now we're in a they're gone, unfortunately. And that's another thing I would say is a challenge that we kind of see in MIH is that, I guess, compassion fatigue is, a better term for it. But then, logistics, well, it seems like everybody wants to do an MIH program, but logistically, how are you going to do it, right? You got a cardiac monitor. If you're going to have an ALS personnel, you need a cardiac monitor. What kind of formulatory you want to carry? What kind of truck you're going to drive to these calls? Is it going to be marked, unmarked? It's going to have sirens. What's the deal? So logistically, it could be a nightmare, if you don't got your everything down.
Yeah, what kind of coverage are you going to provide? Is this going to be 24/7, or is it just going to be a Monday through Friday?
Right.
Yeah.
And then also, like, what are you going to handle? What's your goal with it, right? Like, going to, like, in our instance, since I work for a fire agency, going to city council and saying, oh, we have an MIH program. Yeah, it sounds great to them, to somebody that may not work in the industry, but
and we need a $50,000 cardiac monitor.
Exactly, and they're
and
like
an $80,000 truck, and
right. And to them, they're gonna be like, well, why? We're not just gonna give you that money. Like, you gotta explain to me why. And then, like I said, having goals, having what you're gonna do. I did a community. This is something that they kind of teach, maybe on the more the community side of things, like community nursing, community paramedic. It's something called community needs assessment. That plays really big, into when you kind of ask for these MIH programs or when you want to start one. Exactly, because that's the other part of it, right? Financial. Who's paying for this? And are you going to get reimbursement, right? For what you're doing? So, trying to get all that, through is going to be, it's just going to take time. It's just one of the new kids on the block. You got to look at the financial part of this whole thing. Is this really going to make a difference? Is this something that's going to, what is the ultimate goal here of that? Because financial, how are you going to hire? How are you going to do this? How are you going to do that? Right. And then there's the other aspect.
Sounds like a chief problem.
Yeah, exactly. Right. Above my pay grade right now. The part of the financial is, some people will say like, oh yeah, hospitals reimburse, MIH programs. Oh, okay. How are you planning on doing that? And you're asking them for money? Good luck, right? Essentially, but you got to prove to them why that happens. Like, and you can get creative with the finance part. In my agency, right? There's a reason I still go to 911 calls. Guess what? I cancel an engine, I cancel a rescue. I just save the city money. I run so many calls in a year and I cancel them because I just I can handle it by myself. They're not needed. Well, I just paid for my own salary right there. And that's what reflects on the city.
And the handoff to EMS is, I don't want to say cleaner, but it's much more efficient. The information you provide the crew when they arrive is on point.
Absolutely. Even if it's, it's maybe somebody I've never seen, right? I have the time to sit there and try to gather that from that patient. on a 911 scene. And, I'm working with them. And biggest thing, I work with a lot of nursing homes too. When these responses happen, they know me by name at this point. And when I show up, and their patients are not my MIH patients. But when that 911 system gets activated, I try to intercept it and see, okay, is this just what was considered an in-facility transfer pretty much, or because of X, Y, and Z? Or is this a more bigger issue, like an actual more emergent issue for this patient? And obviously having that line of communication, now you're bringing in, right, that nursing kind of, the nursing staff, whatever they are. I know depends on what floor you're on.
Right. What level of care they're providing.
Exactly. And just talking with those people now, you have a better transition. You got a better relationship with them. So when you do run the 911 call again, hey, they're more willing to be more open with you. I think is this, and I think because of X, Y, and Z. And they see those patients every day.
You're building personal relationships, and they're seeing the value you're bringing in.
Exactly. And just, that's just going to lead to better patient care. I mean, just one of the things we struggle with as healthcare providers is, everybody communicating with each other kind of.
Yeah. Where do you see MIH going the next 5-10 years? What's the future of the program? You see it expanding?
For sure, I would say expanding. I think MIH, you're going to start seeing it on every street corner. I think a lot of people, a lot of companies, even agencies, they're going to start moving towards that model. A classic example I use is, when firefighters first came about, right? They didn't have fire marshals, right? Now you go to any fire agency, there's fire marshal's office there, right? Doing prevention, right? Preventing fires. And I see MIH kind of going that way in that direction as well. I see more bringing on more roles as well. I think this has actually happened already, but more out like in LA, I think. And actually, there's a place in one of our metro areas that have nurse practitioners and physician assistants that are doing MIH stuff, and that's awesome. They're still running calls every now and then too, if it's something low acuity, even maybe critical. But now that you have a more advanced provider on scene, like, yeah, hey, you're just going to the hospital because you got the sniffles. Well, here's a prescription. This is what you're going for, right? Well, I'll give it to you right now.
Right.
You need your medication refilled? Okay, well, here you go. Boom, problem solved. I definitely see it building that more levels in there for sure.
What advice would you give to an EMS agency if they were looking to start an MIH program?
So I would say, especially based on experience, find people that really want to do this, because this job can be tough, in certain aspects. I hear people tell me all the time, like, it looks great. It looks like what you're doing is gravy. Well, I hope that's because I'm making it look easy, so hopefully I'm doing it right. That's kind of the old saying. Yeah. Really find somebody who's dedicated to really doing this, because it's a wild west in MIH right now. There's no standard. Whatever you can invent, have somebody who's creative, who wants to see things grow. Somebody who, on top of that, understands your community. That's actually worked there, right? Because that's going to be the best way to bring in those providers, that whatever it is, community paramedic, a nurse. Those people are going to be what either breaks you or makes you.
Right.
Is that level of care. And I would say too, if you're starting an MIH program, always make sure you look at your community that you're in, do what's called the community needs assessment. But what can you fix in your community? What would you want to fix? And would an MIH program help fix that?
Excellent advice. Derek, thank you so much for coming in.
No, appreciate it, Jason. Thank you so much.
This is an excellent conversation, and best of luck out there.
Yeah, thank you. We'll keep going at it.
Thank you for listening to In Service, the EMS Podcast, where frontline experience meets leadership insight. If you have found value in this conversation, please like, subscribe, share, and leave a comment. You will find links in the episode notes.